of diabetic ketoacidosis in children. So this is going to be a bit interactive, and this is an outline of what I'm going to discuss. I'm going to look at the definition. We are going to briefly look at the epidemiology. We'll look at the pathophysiology and talk a little bit about the clinical presentation, and then we'll delve into the management and end with a small discussion on prevention of DKA. So I will begin with a case. And this is a 4-year-old girl who presented to our pediatric emergency unit at Kenyatta National Hospital about 3 weeks ago. This is a child who had been on management at in one of the county hospitals, had been there for 2 days before being referred to us. And she had a 2-week history of polyuria, polydipsia, and abdominal pain, and a 3-day history of cough, chest pain, fever, and drowsiness. So she was reported to have previously been healthy, and there was a history of diabetes and the paternal grandfather. So on examination, she was noted to be alert but confused. Her pupils were equal and reactive to light. She had deep acidotic breathing. Her extremities were cool with a prolonged capillary fill time. Heart rate was 150 beats per minute, and blood pressure was not taken at that time. Her oxygen saturation was 89% in room air, and she had a respiratory rate of 40 breaths per minute. Temperature was 37.3 degrees Celsius, and her weight was 14 kilos. So these are the preliminary laboratory results. And looking at the blood gas, the pH was found to be 6.9 with a PCO2 of 0.8, which was low. And we also had a bicarbonate level of 1.3. Other parameters to note are a normal potassium of 3.9 and a sodium of 143, and had an elevated chloride of 117. There was an anion gap of 23.7, and her blood glucose was 23.1. Lactate was normal. So a dipstick urinalysis was done, and she had a ketonuria, large ketonuria of 3+, and glucosuria of 3+. So based on these parameters and the clinical presentation, an impression of diabetic ketoacidosis was made in a child with shock. So I will request the host to launch the first poll question. So we'll have a few poll questions. I will just request you to just type, send in your answers. The poll is anonymous. This is just part of discussion. So with that history in mind and with the preliminary labs, how would you classify the severity of DKA in this child? Is it mild diabetic ketoacidosis? Is it moderate diabetic ketoacidosis? Or is it severe diabetic ketoacidosis? The poll is anonymous. So I think we can have a look at the poll result. Okay, so majority, that is 54%, say it's severe diabetic ketoacidosis. So let's see. Okay, we can end that poll. Okay, so just looking at the definition of DKA, diabetic ketoacidosis is basically an acute, major life-threatening complication of diabetes that usually requires emergency management with fluids and insulin. And for a diagnosis of DKA to be made, we usually require 3 parameters. So the patient should have hyperglycemia, which is defined as a blood glucose of above 11 millimoles per liter. We should have ketosis. So the presence of ketosis can be identified either by measuring the ketones in blood or measuring the ketones in urine. Most of our facilities do not have access to measurement of blood ketones. So we usually check for ketones in urine. So if you're doing a urinalysis, then if the patient has moderate or large ketonuria, which is equivalent to 2+ or more, then that is actually diagnostic of ketonuria. And if you're measuring your serum ketones, then a level of 3 millimoles per liter and above is indicates the presence of ketonemia. And then the third parameter is the presence of acidosis, as defined by a pH of less than 7.3 and a bicarb of less than 15 millimoles per liter. Now, rarely you may actually have what we call euglycemic ketoacidosis. And euglycemic basically means the blood glucose is normal. And this can happen in patients who are partially treated. Probably they have been on insulin or other hypoglycemic drugs. It occurs also in pregnancy. And it can also occur in patients who are consuming little or no carbohydrates. For example, patients who are fasting or who have eating disorders, or patients who are on a low carbohydrate, high fat diet, or what we call a ketogenic diet. So occasionally this kind of patients may actually get a euglycemic ketoacidosis. So the presence of a normal blood glucose does not completely rule out the presence of diabetic ketoacidosis. So once you have made the diagnosis, then you need to further classify the patient into mild, moderate, or severe. So severe ketoacidosis is defined as a pH, the presence of a pH of less than 7.1 and a bicarbonate level of less than 5. Then a patient who has moderate DKA will have a pH of between 7.1 and less than 7.2 and a bicarb of between 5 and less than 10. Then mild DKA is defined as a pH of between 7.2 and less than 7.3 and a bicarbonate level of 10 to less than 15. So back to our patients, the pH was actually 6.9 and the bicarbonate level was 1.8. So the correct answer is indeed severe diabetic ketoacidosis. So in one study that was done here in KNH by Musoma et al. Among children with the DKA, they actually assessed the distribution of the severity of DKA, and they actually found that about 76% of the children are presented with either moderate or severe DKA, with the larger proportion presenting with severe DKA. So just looking at the epidemiology, DKA is the leading cause of morbidity and mortality in children with diabetes, and it has a wide geographic variation at onset, ranging from 15 to 70%, but this incidence is actually much higher in developing countries. And of note is that the rate of DKA is actually inversely related to the incidence of type 1 diabetes. And this means that in countries that have a low incidence of type 1 diabetes, the incidence of DKA is actually higher. And probably this is related to the level of knowledge of the population on signs and symptoms of diabetes, which might influence how early they will present to health facilities. So I'll request the host to launch poll number 2. Okay, thank you. So risk factors for diabetic ketoacidosis include the following, except 1, age above 2 years, 2, previous history of diabetic ketoacidosis, 3, poor access to medical care, 4, adolescent girls, and 5, binge alcohol consumption. So the question is, which among these is not a risk factor for diabetic ketoacidosis? Okay, so let's see the answers. Okay, so here we have a mixed response. So majority actually say adolescent girls are not at risk for DKA. That is 51%. And then we have 31% saying age above 2 years is not a risk factor for DKA. So let's You can close the poll. Let's just delve a bit into this. So in one study called the Search for Diabetes in Youth study by Rios et al., they actually found that the incidence of DKA at the time of diagnosis was at 25%. And this was actually higher in patients who had type 1 diabetes, where the incidence of DKA at diagnosis was 29%, and much lower in patients with type 2 diabetes. And so these are some of the risk factors for DKA at onset of diagnosis. So age about less than 2 years is actually a risk factor for diabetic ketoacidosis. Factors that limit access to medical care also increase the risk for DKA, and this includes lack of medical insurance, poor or lower socioeconomic status, ethnic minority groups, because that might also influence their ability to access medical care. And then delay in diagnosis, or patients who have had symptoms for a very long time before presenting to hospital are more likely to present with DKA. And I already alluded to the fact that residents in a country with low prevalence of type 1 diabetes is actually a risk factor for DKA. So the answer to that poll is actually age younger than 2 years. Now, looking at risk factors for DKA in children who have previously been diagnosed with type 1 diabetes, some of these factors include binge alcohol consumption, patients who might have gastroenteritis and are unable to maintain hydration, inappropriate interruption of insulin pump therapy. Now, insulin pumps use short or fast-acting insulin only, short or rapid-acting insulin only. So what this means is that if there's any interruption in the insulin supply, if, for example, the pump breaks down, it means the level of insulin in the body for these patients will actually drop very fast. So they're at high risk for developing DKA. Then patients who have poor metabolic control or have a previous history of DKA are actually at higher risk of getting subsequent episodes of DKA. Again, poor access to medical care. So interestingly, studies have found that peripubertal and adolescent girls are actually at higher risk of DKA compared to their male counterparts. And we still don't know exactly why this is so. And then, of course, patients who have psychiatric disorders, including eating disorders or difficult family circumstances. Sometimes we've seen, especially adolescents, patients who either skip insulin or even inject themselves insulin because they're trying to either get attention or try to get themselves out of a difficult family circumstance. So these are things to always look out for when you have a patient who has diabetes and they present with DKA. So I will just quickly remind us about the physiology of carbohydrate metabolism, because it's important for us to understand the pathophysiology of DKA. And so carbohydrate metabolism is basically regulated by two main groups of hormones. We have insulin, which is an anabolic hormone, and then we have the counter-regulatory hormones, which are catabolic hormones. These include glucagon, growth hormone, catecholamines, and cortisol. So what does insulin do? So basically, insulin is important for the utilization of glucose. So it promotes use of glucose as an energy substrate, and it promotes its storage as glycogen. In addition to that, it promotes protein formation and also storage of fats as triglycerides. Now, the counter-regulatory hormones do exactly the opposite. So they promote what you call glycogenolysis, which is breakdown of glycogen from the liver, as well as from adipose tissue and as from the muscle cells. And this is done to generate more glucose. It also, they also promote proteolysis, which is basically breakdown of proteins to generate glucose through a process of gluconeogenesis. And then thirdly, we have an increase in lipolysis, which is basically breakdown of fats into free fatty acids and ketone bodies. Ketone bodies are an alternative source of energy when you don't have enough glucose. So and this is why patients with DKA usually have an increase in ketones and ketoacidosis. So for a patient to develop DKA, they usually must have both a relative lack of insulin and a relative overactivity of counter-regulatory hormones. So just to summarize the pathophysiology, so basically what happens in DKA, the patients have absolute or relative insulin deficiency. And then you can have situations such as stress, infection, triggering an increase in the counter-regulatory or what we call stress hormones. Okay, and what these hormones do is basically, as I already mentioned, they cause increased lipolysis, resulting in increased free fatty acids and generation of ketones. Okay, and ketones, ketone bodies are acidic basically, so the body tries to buffer that, and this results in a reduction in the alkali reserve in the body, and this results in ketoacidosis. Now, secondly, we have, because of deficiency of insulin, the glucose is not able to enter the cells. Okay, so we have reduced glucose utilization, and this results in hyperglycemia. Then in addition to that, we have increase in proteolysis and reduced protein synthesis, and basically increase in gluconeogenesis, resulting in hyperglycemia. And then finally, we also have an increase in glycogenolysis, resulting in hyperglycemia. So with this increased blood glucose, we end up with loss of this glucose in urine, and that results in an osmotic diuresis. And this is usually accompanied by a loss in electrolytes and subsequent dehydration. Of course, with dehydration, then there's the risk of impaired renal function. And when you have impaired renal function, that actually worsens your hyperglycemia because your kidneys are not able to clear out the glucose from the body. And of course, because of the hyperosmolarity due to the increased blood glucose, because of the dehydration, we also end up with hyposmolarity, as well as because of the increased blood glucose. So kindly launch the next poll. Okay, so children with diabetic ketoacidosis usually present with the following except A, polyuria and polydipsia, B, nausea and vomiting, C, weight gain, D, shortness of breath, and E, altered consciousness. So basically, which among these do they not usually present with? Remember, the polls are anonymous, so I can't tell who is answering what. Okay, let's see the poll results. Okay, great. So majority, that is 78%, say weight gain is not a usual presentation of diabetic ketoacidosis, and that is correct. So let's close that poll. So this is a study which was done by Kipasika et al. In Tanzania, where they were looking at the common presenting clinical features in children with type 1 diabetes. And they found that majority of the patients presented with the classic symptoms of polyuria and polydipsia. And then we also had a big proportion presenting with weight loss. So weight gain is not usually a feature. So they usually have polyphagia and they have weight loss. Other symptoms that were noted were difficulty in breathing, coma, as well as general malaise. And also they looked at the duration of symptoms before presentation, and they found that the mean duration of symptoms was about 2 to 3 weeks. So usually they will have a preceding history of about 2 to 3 weeks before they present to hospital. So of course, once they present, what are the signs that we'll present with? They may have various degrees of dehydration. They may present with tachycardia. They may have Kussmaul's or deep acidotic breathing. They may have a fruity breath, and this is usually due to the presence of acetone. They may present with abdominal tenderness, and abdominal tenderness it's something that you need to have a high index of suspicion for, because some patients have actually been misdiagnosed as having acute abdomen, only to later be discovered to have had diabetic ketoacidosis. And then they may also have altered consciousness. Kindly launch the next poll. So how much fluid did you administer in this child? Our child, remember, was 14 kilograms. So the first option is 10 milligrams per kg of normal saline over 30 minutes. And if perfusion improves, continue with 3,380 mils over 48 hours. The second option is 10 mils per kg of normal saline over 1 hour. And if perfusion improves, continue with 6,120 mils over 48 hours. And the last option is 20 mils per kg of normal saline over 15 minutes. And if perfusion improves, continue with 4,900 mils over 48 hours. So let's see the answers. Okay, yeah, so there's a bit of division. So 44% have gone for the first option of 10 mils per kg of normal saline over 30 minutes. And then 3,380 mils over 48 hours. And then 32% are saying 10 mils per kg over 1 hour. And if perfusion improves, 6 liters over 48 hours. So let's see, we can close the poll. Okay, so in terms of fluid management in DKA, normally we recommend that the fluids are corrected in 2 phases. So normally we correct with, we start with a quick phase, during which we correct shock. And then subsequently, we correct dehydration over a longer period of time. That is the slow phase. And what fluid resuscitation does, it basically restores the glomerular filtration rate. And this actually helps to lower the blood glucose level, because it helps to improve clearance of blood glucose through the osmotic diuresis. And it also reverses the progressive acidosis by improving the perfusion. So of note is that insulin should not be started until the child has been adequately resuscitated. So it's important to assess these children when they present. So of course, you need to assess the severity of dehydration. So if a child has some dehydration, that usually corresponds to about 5 to 7% dehydration. If they have severe dehydration, that corresponds to about 7 to 10% dehydration. If you're uncertain about the degree of dehydration and the patient has significant DKA, for example, if they have severe acidosis, then it's safer to assume 10% dehydration. And of course, it's important to get the weight. Always take the weight of the patient. Don't use an old weight, a previous weight, but get the current weight. And of course, take laboratory samples for emergency investigations, including urea and electrolytes. So the first step, of course, is to correct shock. And we follow the usual ABC protocol of life support. So of course, you have to ensure the airway is patent. For patients who are in shock, usually you have to give them oxygen. And then you move on to circulation. So we need to get a large IV cannula or intraosseous access, and it usually require a second cannula. So these patients usually require 2 cannula. So in terms of management of shock, we can give either normal saline or ringer's lactate. 10 mils per kg over 30 minutes. That is if they're in shock. If they're not in shock, then we give the same amount, the 10 mils per kg over 60 minutes or over 1 hour. Boluses can be repeated, boluses of 10 mils per kg until perfusion improves. But in any case, we should not exceed 40 mils per kg in the initial 4 hours because that increases the risk of cerebral edema. So just going back to our patient actually had shock because they had cool extremities and a prolonged capillary refill time. So this patient would actually should actually have received 10 mils per kg over 30 minutes, and that is what they received. So still on management of shock, in the rare event that you are unable to get intravenous or intraosseous access, then you can use a nasogastric tube. And in this case, fluids can be administered at 10 mils per kg per hour until perfusion improves, and then at 5 mils per kg per hour. For this, we can use either ORS or half-strength Daros with dextrose. So once we have corrected the shock, now we move on to the slow phase of rehydration. Okay, so how do you calculate how much fluids to give? So we will administer normal saline or Ringer's lactate. We need to calculate the maintenance, okay? And then we add 10%. Remember, if you're assuming 10% deficit, then you add 10%, which is equivalent to 100 mils per kg. Now, this deficit is supposed to be corrected over 48 hours, okay? So for our patient who was 14 kgs, if you calculate the maintenance, and you can calculate the maintenance using the Halliday-Segua formula, the 100 mils per kg for the first 10 kg, followed by 50 mils per kg for the next 10 kg, and then 20 mils per kg for every kilo above 20 kg, okay? Or you can even use reference charts that already have the maintenance calculated, like the basic pediatric protocols. And then you get your, calculate your 10% deficit. So these fluids are given over 48 hours, and we need to monitor the glucose very closely, usually hourly. If once the glucose drops to between 14 and 17, this patient is at risk of hypoglycemia. So we need to add 5% dextrose to the normal saline or Ringer's lactate. If, again, intravenous or intraosseous access is not available, then the patient may be rehydrated orally or by a nasogastric tube with ORS at 5 to 10 mils per kg per hour. So this chart here, this is it's from the ISPAD guidelines, from the International Society for Pediatric and Adolescent Diabetes guidelines. And it's available also in the National Diabetes Guidelines. Is a page with this chart. So what we have here is the amount of fluid has already been calculated for us based on the weight of the child. So it makes life really easy, because sometimes we've been working for so long, you're tired. When you have to do the maths, there's a risk or a chance that errors can happen. So it's always best to just refer to charts like this. So for example, our 14 kilo 4-year-old girl, if you look at that, so here we have the maintenance, which is calculated over 24 hours. And then here we have the maintenance plus 5% of body weight, which is what you're giving over 24 hours. Remember, over 48 hours, we are replacing the 10% over 48 hours. So that has been divided into 2 for us to get what you're going to give over 24 hours. And then here we have the amount of fluids in mils per hour. So for our 14 kg girl, the amount of fluid would give is 1,690 mils over 24 hours. And if you multiply that by 2, that will give you 3,380 mils over 48 hours. Yeah, kindly launch the next poll question. So how much insulin would you administer to this 4-year-old girl with 14 kilos? Is it 0.7 units per hour, 1.5 units per hour, 3 units per hour, or 6 units per hour? Okay, let's have the answer. Okay, so 49% say 1.5 units per hour and 43% say 0.7 units per hour. Okay, let's see. You can close that. So our next step in management of DKA is management of hyperglycemia. So just know it's important to note that the first step is not management of hyperglycemia. It's actually correction of dehydration, and then we move on to correction of hyperglycemia. So insulin should be started only once the patient is hemodynamically stable, and usually this should be at least 1 hour after starting fluid replacement therapy. So what does insulin do? Of course, it lowers the blood glucose, but in addition to that, it stops ketogenesis and reverses the acidosis. So how much insulin do we give? So normally we use either rapid or short-acting insulin, which is also called regular, and we give it as an infusion at 0.1 units per kg per hour. But if the child is below 5 years, we actually give 0.05 units per kg per hour. In fact, in many centers right now, they're actually using 0.05 units per kg per hour for most patients, even for adult patients. And it has been found that the outcomes are the same. It takes a little longer for the blood glucose to normalize, but at the end, the outcomes are still the same. So it's ideal to use an infusion pump. And we aim for a glucose reduction of not more than 5 millimoles per liter per hour. So if you note that your blood glucose is dropping more than that, by more than 5 millimoles per liter per hour, then you need to add 5% dextrose to the solution. Now, if insulin infusion is not possible, or you're unable to get IV access, then you can actually administer subcutaneous, short-acting or regular insulin into the upper arm, usually at 0.6 to 1.2 units per kg per 24 hours, divided 4 hourly. So back to our patient, our girl, she was 14 kilos and she's 4 years old. So the correct answer is actually 0.05 units per kg per hour, which would give us 0.7 units per hour. So the correct answer was 0.7 units per hour. So we no longer give an initial insulin bolus. That used to be the practice, but that is no longer recommended. Yes, it will reduce the time to correction of blood glucose, but it will not change the time to correction of acidosis. So there's actually no benefit. And also, when you give a bolus, it may reduce the serum osmolality very fast, which increases the risk of cerebral edema in these patients. It's important that insulin infusion is continued until the ketones have cleared. So don't stop insulin once the ketones have cleared. Don't stop the insulin infusion before the ketones have cleared. So this is a practical example of what you do if you don't have an infusion pump. So using our 14 kg 4-year-old girl, who we said will require 0.7 units per hour, what you can do is get 14 units of short-acting or regular insulin, put that into 100 mils of normal saline, and then you run that at 5 mils per hour. That will actually give you 0.05 units per hour. If you're aiming to give 0.1 units per kg per hour, for example, in a child who is older, then you'll run that at 10 mils per hour. So this is an excerpt from the basic pediatric protocols. And it's a useful guide in determining how many drops of fluids, to calculate when you want to give fluids. It's always good to have the pediatric burettes as opposed to the adult burettes, because it actually makes life much easier. And this is, of course, in a setting where you don't have infusion pumps, which is the situation for many of us. So if, for example, we have a patient who requires, 300 mils of fluids in 24 hours, and you need to give 13 mils per hour. Okay, if you're using a pediatric burette, that will be 13 drops per minute. If you're using an adult giving set, it will be 4 drops per minute. So if we take our patient, for example, who requires 5 mils per hour, Okay, it means if you're using a pediatric burette, it will be 5 drops per minute. But if you're using the adult giving set, then it will be about 1 to 2 drops per minute, which is very tricky. So it's always advisable to use the pediatric giving set. So this reference is available in the pediatric basic protocol. So always utilize it. Can you launch the next question? So if you do not have access to serum potassium measurement, what should be done? So one is start potassium supplementation as there is total body potassium depletion. 2 is immediately transfer the child to another clinic, even if this is more than 2 hours away. Or 3, obtain an ECG. The poll is anonymous again. Okay, let's see the answers. So 55% say start potassium supplementation as this total body potassium depletion, and 42% say obtain ECG. Okay, so let's see. Let's talk a bit about potassium, the pathophysiology of potassium. Why do these patients tend to have low potassium? So of course, because they don't have insulin, insulin normally drives potassium into the cell. And in addition to that, when they don't have insulin, there's increased breakdown of proteins. And this results in efflux of potassium from the intracellular to the extracellular space. Because of the acidosis, again, we have an accumulation of hydrogen ions extracellularly. And if you remember our physiology, hydrogen ions usually exchange with potassium at the cellular level. So when you have an increase in hydrogen ions, you'll have hydrogen ions shifting intracellularly in exchange for potassium ions, which will shift extracellularly. So at the end of it, you have an increase of potassium in the extracellular space. So once this happens, this potassium is then lost either via osmotic diuresis, or because the patient is dehydrated, we end up with activation of the renin-angiotensin aldosterone system. Okay, aldosterone usually increases loss of potassium in urine. So when you have hyperaldosteronism, you end up with kaliuresis. So these are mechanisms by which now the potassium is lost, and we end up with hypokalemia. In addition, if the patient is vomiting, then of course you'll have also gastrointestinal losses of potassium. So it's important to note that your serum potassium levels, your measured levels may be low, normal, or high, even when the total body potassium is depleted. So a normal potassium level does not actually truly mean that the total body potassium level is normal. So what do we do? So it's important to determine the levels by laboratory tests. I believe most of our facilities are able to at least get electrolyte levels. But in the event that that is not available, then you can utilize an ECG, look at the waves, okay, which can guide you on whether the patient has a hyperkalemia or a hypokalemia. And then we start replacement of potassium once the serum value is known or the patient passes urine. Now, the risk of starting potassium without knowing the levels or not doing an ECG is that if the patient has acute renal failure, then they're likely to have hyperkalemia. And then if you give potassium to this patient, you can actually cause a cardiac arrhythmia and death. So it's always important to either get a level or do an ECG. However, in situations, if the situation is really dire and you're in a place where you really don't have a lab value and you have started insulin, within 4 hours, actually potassium should be started because insulin causes hypokalemia. So if your patient is on insulin infusion and they possibly had hypokalemia, then you're actually worsening the situation and they can also get a cardiac arrhythmia, dysrhythmia or arrhythmia. So how much potassium do we give? Usually we add potassium chloride. That is what is commonly available, but you can also use potassium acetate or potassium phosphate or a combination of any two of those three at 40 millimoles for every liter of fluid. If the patient, if the child was hypokalemic, Then we start potassium replacement before initiating insulin at 20 millimoles per liter. And then when we are starting the insulin, we increase that to 40 millimoles per liter. In the rare event that IV potassium is not available, then you can replace potassium orally by giving potassium-rich fruits. If we are rehydrating the patient with RS, then we don't need to add potassium because already it has potassium. And it's important to monitor the levels every 2 to 4 hours. So back to our case, can you launch the next poll question? Can you launch the next poll? Thank you. So what is the true serum sodium in this patient? So you can see here the measured sodium was 143. So the question is, what is the true serum sodium? Is it 139? Is it 143? Is it 149? Or is it 153? Okay, let's see the results. Okay, so majority think them it's 130, oh sorry, it's 139, that's 45%. And 30% think it's actually the measured value, which is 143. So let's see. Let's talk a little bit about sodium. So many patients with the DKA usually will present with the hyponatremia. Our patient did not have a hyponatremia, but majority of them, many of them will usually present with the hyponatremia. And why do they have a hyponatremia? One is, and we say hyponatremia in quotes, because it's not necessarily a true hyponatremia. So one is because of the hyperglycemia. Because of the increased high serum osmolarity due to the hyperglycemia, we get water being driven from the intracellular to the extracellular space, resulting in dilutional hyponatremia. Secondly, children with DKA or patients with DKA tend to have hyperlipidemia because of the increased breakdown of fats to generate ketones. And depending on the machines that are being used in the lab, the hyperlipidemia can cause displacement of sodium in those some of the assays, resulting in a factitiously low sodium values. And thirdly, we can actually have true loss of sodium through urine, through osmotic diuresis, and through vomiting. So what you're saying is whenever a patient has hyperglycemia, whenever glucose goes up, sodium tends to come down, yeah? But it is not a true hyponatremia. And for this reason, it's important to calculate the true serum sodium for all patients who present with DKA. So, and we have the formula here for calculating. We just need the measured, we require the measured sodium, and we require the glucose. And this is the formula in millimoles per liter. So every time you get your sodium level or your UECs, always calculate the corrected sodium level. So for this patient, our measured sodium was 143, but using the formula for corrected sodium, we actually got a serum sodium of 149, which is high. So this patient is a bit unique because they had been prior to being referred, they had been in a facility for 2 days and they were receiving normal saline. And if you remember, the blood gas showed they had a hyperchloremia of 117. So this might, the sodium in saline infusion probably explains why they had a hyponatremia and a hyperchloremia. So for correction of acidosis, now, correction of acidosis is not recommended in DKA because usually it will correct with insulin infusion and with rehydration. So unless the acidosis is very profound with a pH of less than 6.9, together with the impaired cardiac contractility, or there is life-threatening hyperkalemia, So in only those two situations would you consider administration of bicarbonate. Bicarbonate actually increases the risk of cerebral edema in these patients. So if it's considered necessary, then we can give it cautiously at 1 to 2 millimoles per kg over 1 hour. When we have patients with DKA, it's always important to look for underlying causes or triggers for DKA, and infection is one of the common triggers that we need to look out for. It's usually very difficult to exclude infection because these children tend to have an increased white cell count due to stress. But if infection is suspected, then it's important to take the necessary samples, for blood cultures, urine cultures, or any other investigations as per the clinical presentation. And if infection is suspected, then we treat with antibiotics as per the basic pediatric protocols or guidelines, antimicrobial guidelines. So what are some of the complications of cerebral edema, of diabetic ketoacidosis? And of course, the most dreaded is cerebral edema, but there are several other complications that we might encounter, including hypokalemia, and especially if you start insulin and you're not supplementing potassium, there's that risk of hypokalemia, hypoglycemia, hyperchloremic acidosis. We need to look out for this. Sometimes you'll have patients who have the ketones have cleared, but they still have persistent acidosis, and we're wondering why. And a lot of times you'll realize that they actually have hyperchloremic acidosis. Remember, these patients are getting normal saline, which has chloride, and we're also replacing potassium with potassium chloride. Okay, so this puts them at risk of getting hyperchloremic acidosis, and that's why it's recommended that if you have other salts to replace potassium, like potassium acetate or potassium phosphate, then it's better to use those or use them in combination. So you'll suspect hyperchloremia if your chloride to sodium ratio is more than 0.79. But the good news is that hyperchloremic acidosis most of the time resolves on its own. Then, of course, other complications include aspiration pneumonia, acute kidney injury, and myocardial infarction. So looking at mortality in DKA, the mortality rate is estimated to be about 0.15 to 0.3%. Here in Kenyatta, in the study by Musoma et al., they actually found the mortality rate to be 6.9%. And of note is that 60 to 90% of deaths occur in association with cerebral edema. So this is the complication to look out for. So in the same study by Musoma et al., they also looked at factors associated with increased mortality. And what they found is that patients who had serum creatinine levels raised more than 2 times above the normal level had a 5-fold increased risk of mortality compared to those who had normal creatinine levels. Patients who had anuria for 12 hours had a 9-fold increased risk for mortality. And patients who had altered level of consciousness, again, had a 5-fold increased risk of mortality. So what about the patient who presents with altered sensorium? What is the cause? So these patients have serum hyperosmolarity because of the hyperglycemia. Most of them are usually dehydrated, have severe dehydration, and of course they have acidosis because of the increase in ketones. So these factors together cause an increase in osmolarity in the brain cells, and that contributes to altered consciousness. But of course, we always have to have cerebral edema at the back of our minds for all these patients. And I'll just briefly look at cerebral edema. It's been found to occur in up to about 1% of patients who have DKA, and it's actually the major cause of death in childhood DKA. Among the children who get cerebral edema, 20% will die and 20% will have some neurologic sequelae ranging from mild to severe. So basically 40% will have adverse outcomes. And again, in the study by Musoma et al. At Kenyatta, they found that almost 50% of the children with DKA manifested some signs of altered level of consciousness. So that tells you how common altered consciousness is as a presenting feature in children with DKA. So why do these children have cerebral edema? So At this time, no one really knows the cause, but there's some hypotheses. Many of these patients actually usually, by the time they're presenting, they have some degree of cerebral edema, but this is worsened by the treatment they receive. So it's thought that they could be dysfunction in the blood-brain barrier, resulting in excessive accumulation of water and solids in the interstitial space. And there's also the cytotoxic theory, which may result from excessive accumulation of water and solids in the intracellular space, resulting in cytotoxicity. And you can have a combination of both factors contributing to the development of cerebral edema. Of note is that patients with cerebral edema have been found to have with DKA basically have been found to have levels of antidiuretic hormone as high as 50 times the normal level. And this may contribute to increase in free water and hyponatremia, thus worsening the increasing the risk of cerebral edema. So this therefore tells us that we need to be very cautious in rehydrating these patients. Okay, I already talked about calculating the true sodium level, and one of the parameters that we need to monitor is actually the sodium level. So, like I said, many of the patients will come with the hyponatremia, which is not a true hyponatremia. And as we initiate treatment, we expect that sodium to gradually rise to the normal level. So if that is not happening, if the sodium remains the same, okay, or it's decreasing, then that tells you that this patient is at risk of cerebral edema. The second thing is that we need to monitor the effective serum osmolality. And we have the formula here. You just need your plasma sodium and your glucose level to calculate that. So we always need to calculate this and monitor every time we measure our electrolytes. So normal effective serum osmolality is 275 to 295. And again, this is usually elevated in the beginning, and we expect it to normalize. Normally, it's as high as 300, 320. Okay, when they present with DKA. But once we begin treatment, it's supposed to gradually come down to normal. So if you have a rapid decline or a very slow decline, but to a subnormal range, then that may indicate an excess of free water entering the vascular space, and therefore an increased risk of cerebral edema. So what are some of the risk factors for cerebral edema? I've mentioned some of them. So of course, age younger than 5 years, those are at patients who are at high risk for cerebral edema, patients who have new onset diabetes, patients who have severe acidosis, rapid administration of hypotonic fluids. So if you give more than 50 mL per kg in the first 4 hours, that patient will be at risk of for cerebral edema. Intravenous bolus of insulin, I've already mentioned that, and early intravenous infusion of insulin administered within the first hour of fluids, that is a risk factor for cerebral edema. Then, of course, persistent hyponatremia, use of bicarbonate, and delayed diagnosis. So there's this study by Glaser et al., which was looking at the timing of presentation of cerebral edema. And they found that most of the patients presented within the first 13 hours of treatment, with a peak between 3 and about 6 hours, and then a second peak between 9 and 13 hours. There were 3 children who had presented with cerebral edema before initiation of treatment. And this tells us that we need to be very vigilant during the first 12 to 24 hours while managing these children. It's important to note that the warning signs will usually come early before the onset of cerebral edema, and also that the imaging, CT or MRI, may not be seen early in cerebral edema. So don't be in a hurry to start, don't be in a rush to get a CT scan or an MRI, because in the early stages, you may not find anything. And this tells us that cerebral edema is basically a clinical diagnosis rather than a radiological diagnosis. So these are some of the signs. Altered sensorium. If the patient has sudden and severe headache, okay, you may have ophthalmoplegia or pupillary changes like, anisocoria. if the patient has persistent vomiting, or they have a sudden onset of vomiting, or they had vomiting which resolved and now it has returned, think about the possibility of cerebral edema. Then you may also get patients presenting hypoxemia, incontinence. So if a patient has increased urination or incontinence, then you need to have a high index of suspicion for cerebral edema. And what this could mean is that because of the cerebral edema, remember the antidiuretic hormone is produced in the pituitary. So because of that increased intracranial pressure, we have impaired blood supply to the pituitary, which can impair the production of the antidiuretic hormone, thus resulting in diabetes insipidus. And then, of course, the Cushing's triad. So I will not go through this score in detail, but it's a good score to just look at later on, just to help us evaluate the possibility of the presence of cerebral edema. So we have diagnostic criteria, we have major criteria, and then we have minor criteria. So if we have one diagnostic criteria or two major criteria, or one major and two minor criteria, that gives you a sensitivity of about 92% in identifying the presence of cerebral edema in these patients. And it's important to note that by the time the patient is meeting these diagnostic criteria, usually they are already significantly affected. So how do you manage the patient if you suspect cerebral edema? Of course, the first thing is to reduce the rate of fluid administration to about 70%. Then you can use mannitol or hypertonic saline. Elevate the head of the bed to 30 degrees, put the head in the midline. You may require to give nasal oxygen if they're hypoxemic, and occasionally intubation may be required if the patient has impending respiratory failure. So, so what are the things that we need to ensure that we have in place to ensure that our patients with DKA get the best care? It's important that these patients are managed at the best available site of care as much as possible. And what is this best available site of care? So as you will see later, these patients require very close monitoring. So we need nursing expertise. Okay, we need laboratory support because we need to do a lot of laboratory investigations very frequently. Of course, we need clinical expertise. So if you're in a facility where you don't have, for example, have an endocrinologist, there's always the option of consultation. It's very important to have written guidelines. And it's also very important to have a DKA monitoring form. And I'll just look briefly at that in the coming slides. So this protocol should be available to all the units that manage pediatric patients with DKA, including the clinic, casualty, the wards, and the ICU. So in terms of monitoring, like I already mentioned, these patients require close monitoring. So we need to monitor the vital signs, the level of consciousness, and the blood glucose level hourly. We need to monitor ketones. So if you're monitoring urine ketones, that should be done with every void. If you're monitoring blood ketones, then that should be done every 2 hours. Then of course, fluid intake and urine output should be monitored and recorded. And UCs should be monitored every 2 to 4 hours. And it's important to use forms to document, because if it's not documented, then it's really not very helpful. It's not done. It's not been done. So when do we transition these patients to subcutaneous insulin and oral intake? So if the patient is not vomiting or they're able to retain orally, the electrolytes have normalized and the acidosis has resolved, then we can actually transition the patient to subcutaneous insulin, and they can start taking orally. And most patients usually should start taking orally within 24 hours of admission. So this is just a sample of a monitoring form that you can use for these patients in DKA. So all patients with DKA usually should be admitted in an ICU, especially moderate and severe DKA. Yeah, because DKA is a potentially lethal condition, and its management is also potentially lethal. Yeah, we've talked about the risk of hypokalemia and hypoglycemia. So these are things that need to be monitored closely. But there's of course the challenge of ICU space and inadequate ICU beds. But we should always aim to admit these patients in ICU. So patients who have altered level of consciousness, children, very young children under 5 years, those who have risk factors for cerebral edema, which we've already mentioned, and those who have severe DKA, or young children with moderate and severe DKA should always be admitted to ICU as much as possible. So I'll just, as I come to a close, just talk briefly about measurement of ketones. So there are two ways of measuring ketones. You can either measure urine or blood ketones. And just to highlight that when you're measuring ketones in urine, what you're measuring is acetoacetate. But when you're measuring the blood ketones, usually we are measuring beta hydroxybutyrate. Now, why is it important for us to know this? Patients with DKA usually have the predominant ketone body in DKA is usually beta hydroxybutyrate. It's produced, the ratio of beta hydroxybutyrate to acetoacetate is 10:1. So beta hydroxybutyrate is actually a better marker of the presence of ketoacidosis as opposed to acetoacetate. So that is one of the reasons why we prefer measuring blood ketones. And it's very important because monitoring of blood ketones helps, it's useful for early detection and to prevent progression from mild to severe DKA. And for patients, usually you can use ketone meters, which are just similar to the glucose meters. And ketone level of 6.6 millimoles per liter and above is considered high. So normally we'll advise patients who are monitoring this that they need to check their ketones when the glucose is above about 17, if they have an illness or infection, or they have unusual symptoms, or if for some reason they have missed a shot of insulin. So what are the disadvantages of urine ketone testing? One is that the results are not real time, because the urine may have been in the bladder for a long time. So it may not tell you what's actually happening at that point in time when it's being measured. Secondly, it may not accurately reflect the severity of ketonemia because it's qualitative. Okay. Then, as I already mentioned, it doesn't detect the major ketone body, beta hydroxybutyrate. You may also get false positive results and false negative results if the patient is on certain drugs, and it has a short shelf life of 90 days. So there's that risk of someone using, checking urine ketones with strips that have expired, which may not be accurate. Then, of course, a dehydrated patient may not be able to void. So this is just a study. There's some studies that have shown that blood ketone monitoring is actually superior to urine ketone testing in detecting ketosis. So you can see that it has a sensitivity of 80% and a specificity of 100%, and a negative predictive value of 83%. And it's basically shows that, sorry. So it's this is just a study by Shed et al., where they were looking at the trend in the ketones. So we have the total ketone bodies here. We have beta hydroxybutyrate, and then we have acetoacetate. So if you look here, you can actually see the trend in the beta hydroxybutyrate actually reflects the trend that you're seeing in the total ketone bodies. So it is definitely more accurate than measuring the acetoacetate, which is what we check in urine. And also, finally, its use of a measurement of blood ketones can actually shorten the duration of stay of the patient in the ward, because it peaks resolution earlier, resolution of the DKA earlier than if you're monitoring the urine ketones, as you can see. So it's actually something that we should think about going forward as we manage our patients with DKA. So this is just a summary of a guideline, which is available in the ISPAD guidelines and also in the local diabetes guidelines, of a chart that you can use to put up in your facilities for management of DKA in children and adolescents. So we've talked about when to transition to subcutaneous insulin, but how do we transition? That is usually a challenge for many of us. So it is when you are transitioning to subcutaneous insulin, we do not just stop the insulin infusion, PAP, and then move on to subcutaneous insulin, because the patient will get hyperglycemia. So normally we need to overlap. So you can overlap with rapid acting insulin, okay, for 15 to 30 minutes, or with short-acting or regular insulin for 1 to 2 hours. And this is taking into consideration, yeah, of the insulin that you're giving. Or intermediate or long-acting insulin like Lantus for 2 to 4 hours. Some people even overlap overnight. So normally you'll give a dose of 0.3. So for example, if I want to transition patients in the morning, I can actually give them 0.3 units per kg of Lantus, okay? But they continue with the insulin infusion they're getting for a few hours, okay? And then we stop after those hours. So we don't stop one and then initiate the next one. We have to overlap. So for maintenance, the recommended dosage for prepubertal children is 0.5 to 1 unit per kg per day. And for pubertal children is 1 to 2 units per kg per day. So even after we transition our patients, especially for the newly diagnosed patients, education is very important. So we need to educate them about insulin, about how to administer their insulin shots, how to monitor their blood glucose. For the older children, like above 7 years, they also need to start learning how to do this themselves. So diabetes education is very important before we discharge these patients. So finally, how do we prevent diabetic ketoacidosis? Education is very important. It's important to educate, of course, the family. It's important to educate the community on what diabetes is and the signs and symptoms, and that will enable them to, present to health facilities earlier and avoid delayed diagnosis. The family support for patients who are already diagnosed is also very important, so that they're all on the same page. So if you're advocating for things like lifestyle change, it applies to the whole family, not just for that particular child, because it's good for everyone. Then of course, behavioral intervention is important for patients, especially who have maybe psychosocial issues, eating disorders. So this requires involvement of counselors or psychologists to avoid repeated episodes of DKA. And very important is that we need to have teamwork in the services that manage these patients with diabetes. These patients need access to 24-hour telephone services, okay? So that whenever the child is unwell or they've noticed, the glucose have become high, probably over a period, they can actually contact their diabetes healthcare provider, and they can get the necessary advice to avoid them progressing to DKA. So in summary, DKA is a life-threatening condition that requires care at the best available facility, and morbidity and mortality can be reduced by early treatment. Adequate rehydration and treatment of shock is crucial for these patients, and it's important to have written guidelines at all levels of the healthcare system. Thank you very much. I think I can take questions.
Thank you so much, Dr. Priska, for that very, very informative lecture and very interesting lecture. I think from the questions that have been typed out, you've answered most of them already. Let me see if I can get one. So there's Joseph Akunda, who's asking whether the potassium replacement is a constant at 40 millimoles per hour, or we can still calculate the deficit times 0.4 per kg.
Okay, thank you for that question. So for children with DKA, we recommend actually giving the constant of 40 millimoles. But if they have hypokalemia, as I mentioned earlier, we start replacement before initiating insulin at 20 millimoles per liter for every liter of fluid. Then once you start the insulin, you increase that to 40 millimoles per liter of fluid. But you can always adjust that depending on your measured potassium level. So that's why we need to monitor. So sometimes you might find that you're giving 40 millimoles per liter of fluid, but the patient is still hypokalemic. So you actually need to increase that. But usually you give until a maximum of 0.5 millimoles per kg per hour. Yeah.
I think that is clear. Our next question is Sarah is asking, how would you manage a patient, DKA patient who has already been to another facility, and when they're referred, they come with high sodium and chloride, and have already had their IV fluid?
Okay, so you're asking how we'd manage the hyponatremia and hyperchloremia, if I'm not wrong. Yeah. So this is the patient who probably has, like our patient actually had hyponatremia and hypochloremia. So that's a very good question. So like I mentioned, because that's one of the challenges we have with normal saline. They're at risk of getting hyperchloremic metabolic acidosis. And if they have hyponatremia, usually you can, there's the option of actually giving half normal saline if it's severe hyponatremia. Okay, for the hyperchloremia, normally we recommend supplementing potassium with a different substitute, although that's a challenge because they're not always readily available. So instead of using potassium chloride, use potassium acetate or potassium phosphate. But as already mentioned, usually the hyperchloremic metabolic acidosis will clear on its own. So usually it's not something to worry about, but hyponatremia might be of concern. So you can actually use half normal saline for that, or change to Ringer's lactate. Yeah.
Thank you for that answer. The next question, how you would verification, like the 14 kg patient, how you'd administer the insulin as an infusion in the absence of a fluid pump. How did you come up with the calculation?
Okay, so that's a good question and a common one. So we said for a 14K, for a child less than 5 years old, we give insulin at 0.05 units per kg per hour. If they're older than that, we can do 0.1 units per kg per hour. So for our 14 kg child, you take 14 units of insulin, put in 100 mils of normal saline, okay? And then you run that at 5 mils per hour. If you do the maths, that will actually give you 0.05 units per hour, if per kg per hour. If you want to give 0.1 units per kg per hour, then you'll take for the same 14 units of insulin, again, put in 100 mils of normal saline, but you run that fluid at 10 mils per hour. That will give you 0.1 units per kg per hour.
Okay, thank you for that. There's another question in regards to management of DKA. Brenda is asking, if your blood glucose is above 11 and your urine dipstick is ketones +1, would you still consider to manage as DKA?
No, that would not be DKA. Remember we said for diagnosis of DKA, ketones, if you are using urine ketones usually should be moderate or large ketones, okay? Which is 3+ and above, okay? So if it's 1+ is not diagnosis of DKA, yes. So that patient could have hyperglycemia, maybe it's above 11.1, but we would not say that they have diabetic ketoacidosis. And it's also very important to always get an arterial blood gas if you have ketones and you also have hyperglycemia. But a ketone of 1+ is not diagnostic of DKA.
Thank you for that. The next question is about fluids. So which fluid is preferable, Ringer's lactate or normal saline? And the second question is, in a patient with acute kidney injury, and you need to rehydrate the patient as part of the decay management, how would you go about that?
Okay, so I didn't get the second part clearly. I don't know if it's my internet or you're breaking Kalemia, but the first question was, okay, the second question was about acute kidney injury.
Yes.
And the first question, sorry, I seem to have missed that. The first part of the question.
Sorry, so the first part is a patient you're managing for DKA, but they have acute kidney injury. How would you modify their fluid management?
Okay, and the first part of the question, or the other part?
The other question is about that is, what would you prefer to use in rehydration, Ringer's lactate or normal saline?
Okay, so let me start with the question of Ringer's lactate and normal saline. So lots of studies have been done comparing Ringer's lactate and normal saline. Now, the challenge with normal saline is it increases, as I already mentioned, it increases the risk of hyperchloremic metabolic acidosis. But it's also a good volume expander. That is a good thing. So the current recommendations, the international guidelines and even local guidelines recommend normal saline as the first fluid. Studies that have compared normal saline versus Ringer's lactate, apart from that risk of the hyperchloremic metabolic acidosis, did not find any difference in the outcomes between the two patients. The only thing is those who on Ringer's lactate took a bit longer for the hyperglycemia to normalize, but at the end of the day, the outcomes were the same. Yeah, so I would go for either of them, whatever I have available between the two. So the second question about acute kidney injury, yeah, this is a very challenging situation. Because sometimes we've actually had patients who sometimes you suspect have cerebral edema, then you restrict fluids and then they get acute kidney injury, and then what do you do? And then there's the chance that they will probably have hyperkalemia. So in terms of fluid management, it's usually very tricky. And in these patients, we would just manage the patient as we manage the acute kidney injury. So you need to consult your renal team. Of course, we'll now need to monitor our urine output, calculate our input based on the output and insensible losses. I don't know if there's any nephrologists in the audience who can add onto that.
Maybe you can raise your hand if you have any addition on how you'd be able to manage that.
Okay, so Kalemia, are you there? Maybe I can see if there are other questions. Do we still use 48 hours rule of rehydration? This is in connection to the question I asked earlier. I'm not sure which was the question was, but yes, we correct the fluids over 48 hours. Can stress induce hyperglycemia? Yes, stress can induce hyperglycemia. We have seen patients who present with hyperglycemia, but usually they don't have ketoacidosis. And normally once the stressful event resolves, the hyperglycemia resolves. And this is also quite common in neonates who have come with severe sepsis. A lot of them present with hyperglycemia. Kindly repeat on administration of fluids for the first 24 to 48 hours. Okay, so if your patient is in shock, normally you will give a bolus, okay, of 10 mils per kg over 30 minutes. If they're not in shock, then you give that 10 mils per kg over 1 hour. Of course, you reassess, okay? If the perfusion has not improved, you can repeat boluses, but up to a maximum of 40 mils per kg within the first 4 hours. So that is with regard to management of shock. So once that has been sorted, now we move on to the slow phase of rehydration, which we correct over 48 hours. So to calculate what you're going to give over 48 hours, you need to get the maintenance, okay? And then you need to estimate the deficit. So if they have severe DKA or severe dehydration, usually we estimate 10%. Severe is basically about 7 to 10%. So mostly we work with 10% dehydration. So 10% dehydration is equivalent to 100 mils per kg. Okay, so this 10% dehydration, the 100 mils per kg, you will correct it over 48 hours in addition to the maintenance you're giving to the patient. I hope that is clear. What is the latest experience with COVID-19 and DKA? That's a very interesting question. With regards to, I'm not sure with regards to whether it's associated with DKA, we haven't seen in children, among pediatric patients, we have seen a few patients who present with DKA and they have COVID, but they're not that many. And whether there's an association between COVID and new onset diabetes, the jury is still out. There's a lot of research going on. We still don't know whether it's may be a trigger for new onset diabetes. So that the answer to that, I guess, we'll know with time.
Sorry,
Sarah, yes.
I can continue. My phone has just gone off. Yeah.
Okay, yes, Kelly.
Yeah, so just to a bit of the questions. One was asking for infection in a patient with DKA, what class of antibiotics to use?
So preferred class of antibiotics treatment of infection. Some antibiotics cause hyperkalemia. I am not aware of antibiotics, any of the common antibiotics that might cause hyperkalemia, but in terms of preferred antibiotics to use for treatment of infection should be guided as always by what type of infection you suspect. So if you think the patient has meningitis, treat as per the protocols for meningitis. If you think the patient has a urinary tract infection, treat as per the antibiotics you'd normally treat for a urinary tract infection. So there's no preferred class of antibiotics specific to DKA. As far as I know, we use the same antibiotics depending on the infection that you suspect or you have confirmed.
So Francis is asking whether you subtract the total fluids you've given in shock from the 48-hour total.
Yeah, that's a very good question. So that's a very good question. So once you have treated shock, remember you're treating a specific deficit. They are in shock, they had a severe deficit, yeah? So you would not subtract that amount. But if the patient, for example, has been referred from another facility, they have been there for like 24 hours, and then they present to you, when you're calculating the amount of fluid you'll want to give over 48 hours, you will subtract what they have received. You don't start calculating afresh. But the what you have given in shock, you will not subtract. You'll calculate what you've given. You will give what the amount for shock, and then you calculate the rest of the maintenance and an additional 10% deficit to give over 48 hours. I hope I have answered that question.
I think you have. So most people will ask you where you can get the videos and the lecture. So the videos are normally recorded. Maybe someone from the KNH research team can give us an idea of where to find the recorded lecture. But thank you so much for this very informative lecture. I think we've answered most of the questions, but because of time, we'll have to end it here. So I don't know whether there's anyone from the KNH research team who can guide us on
yes, Dr. Pelemi,
to find the recorded lectures.
Hello?
Yes, go ahead. Go ahead.
The recordings of these sessions are normally uploaded on our KNH website under the webinars tab.
Thank you for that. So that's the website under the webinars tab. You'll be able to find this lecture. Thank you again, Dr. Priska Molo, for giving us the lecture. It was very informative. I think we've all learned quite a lot, and it was in every aspect, from when we received the patient until we've managed the DKA and how to transition. In case of any queries, I think the questions can be channeled to the research team, to Dr. Priscan. Thank you all for attending. Okay, I don't think that to call the meeting to a close. Thank you again, Dr. Priska, unless you have any.
No, thank you very much.
Thank you. The meeting is, so we can leave the meeting now. Thank you everyone for attending.